history, patient has a decreased appetite for the past 6 months. Normal sleep habits, no altered sleep pattern, and there is no alteration in the bowel and bladder habits. He's a non-smoker and non-alcoholic. On examination, the patient weighs 55 kgs, height is 158 centimeters, and the BMI is 19.5. The patient is conscious oriented, moderately built, poorly nourished. There is a pallor present. There is no icterus, cyanosis, clubbing, lymphadenopathy, or any fetal edema. The vitals, pulse rate is 78 per minute, regular in rhythm. The BP taken in the right arm sitting position is 120/80 millimeters of mercury. And on examination, the local examination, Burns, there's a scar over the face, including the left eyebrows, left eyelashes, cheeks, and contractures are present from the chin and neck. The neck is in flexed position. Scars present in front of the chest, left arm, and upper part of the arm. There is no restriction of hand movements. And examination of airway, mouth opening is restricted. It is less than 1 finger. Malampati score not able to assess. Thyromental distance is 3 centimeters, and hyomental distance is also 3 centimeters. Sternomental distance is 6 centimeters, and TMJ shows restricted mobility, unable to protrude. The nostril space patency is more on the right side than the left. The provisional diagnosis, 28-year-old male with no known comorbidities, sustained burns injuries 8 months ago over the face, neck, and upper body. With the difficult airway anticipated, is posted for elective post-burns contracture release.
Okay, good. So what is the mouth opening?
Sir, mouth opening less than 1 finger, sir.
Less than 1 finger. Okay. So with this case and background, we'll discuss something about burns. Okay.
Okay, sir.
So tell me, what is burns?
Sir, burns is a wound which is caused by an exogenous agent, which basically causes coagulative necrosis of the tissues, sir.
Okay. So it is a burns as an injury to the skin or other organic tissue, primarily caused because of heat, or it may be due to radiation, radioactivity, electricity, or by chemicals.
Okay, sir.
Okay. So in the same definition, there is called, what is the sources of burns? Okay. What are the sources of burns?
Sources of burns, it could be thermal because of fire, flame injury. It could be moist heat because of it causes scald injury because of chemical burns due to acids and alkali. It could be electric burns and cold burns, frostbite, sir, and because of radiations.
Yeah, radiation. Okay. So main source of burns is heat. It may be dry heat or wet heat. Okay, and the next commonest cause is electrical burns. So okay, electrical burns may be low tension or high tension or due to lightning. All these three comes under electrical burns. So low tension is what we routinely use at the house, which is less than 500 volts, and high tension is something around 500 to 1000 volts, and lightning is more than 7000 volts. So these are the two common causes of burns, heat and electrical. Then of course chemical burns is there, and radiation. So now, what are the types of burns, the degrees of burns?
Sir, first degree burns,
Yeah,
second, and there are 4 degrees of burns,
yeah,
sir.
correct. Yeah,
The first degree is localized to the epidermis alone.
yeah,
The second degree is divided into superficial and deep.
yeah, yeah,
So superficial degree is the dermis and the
yeah.
superficial papillary dermis is
Mm-hmm.
involved.
Yeah,
In deep second degree burns, the epidermis is involved and the deep reticular dermis is also involved.
okay.
And in third degree, full thickness burns involving the epidermis, dermis, and the subcutaneous tissue is also involved.
Yeah,
And in fourth degree, it underlying muscle is also involved in the
yeah.
burns.
Fourth degree underlying skin, subcutaneous tissue, and fascia, bones,
Face,
muscle, and other structures are all involved in the fourth degree.
okay, sir.
And how do you classify burns, minor, moderate, and severe? How do you classify that?
Mm, minor burns is partial thickness. Mm, in adults, it's less than 15 total body surface area percentage.
Yeah.
And moderate is about less than 25 percentage.
So if it is minor, it is first and second degree. Usually, when it covers less than 10% of body surface area, or it is 50% of total body surface area in adults, or 10% in children. Okay. Or full thickness burns involving less than 2% of total body surface area. Okay. And particularly, it should not involve any eye, ear, face, so on. So these are the minor burns. So moderate burns is second degree burns that cover about 10% of total body surface area, or partial thickness of 15 to 25, or full thickness burns involving 2 to 10% of total surface area. And severe is third degree burns covering more than 1% of the body surface area, or the partial thickness burns involving 25% of total surface area. Okay. There are full thickness burns involving more than 10% of total body surface area is called as severe burns.
Okay, sir.
Okay. Any doubt about this? Okay. Then what are the if in the there are several factors which involves or contribute to the severity of burns. Okay. So like the temperature of the burn, duration of contact, how much duration the patient is getting contacted to the burns, then the heat transfer or the tissue conductivity. These are the factors. These 4 factors are involved in to contribute to the severity of the burns. Okay. Then what is the pathophysiology of burns?
So it causes a coagulative necrosis of the epidermis and the underlying dermis. The depth of injury depends on the how much skin is exposed, the heat caused by the agent, and the duration. Then the area is divided into 3 zones: zone of coagulation, of stasis, and hyperemia. The zone of coagulation is the necrotic area where the cells are disrupted. Outside that is the area where there is vessel leakage and vessel damage. And outside that is the vasodilation and the inflammation is happening.
Yeah.
These are the
so
3.
Basically, it is 2 distinct phases are there in the burns. One is acute, that is the ebb phase. That causes the burn shock, which is the dangerous phase where all the inflammatory mediators are released. Usually it extends from 24 to 48 hours. Then is the hypermetabolic or the flow phase, where the hypermetabolism occurs, hypovolemic shock occurs. Usually it occurs after 48 hours. Okay. Then come to how do you assess the severity of the burns?
By using Wallace rule of nine, rule of nine, sir.
Okay.
So the head is given 9% front and back.
Okay. Okay.
The chest, the anterior part of chest is 9. The
Okay.
back is 9.
Okay.
Each of the arms is 9% front and
Yeah.
back.
Good. Good.
The perineum is 1%.
Yeah.
The leg each front and back is 9 each.
Yeah. So totally it comes under 100%. And
100, yes, sir.
roughly that 1% is roughly it corresponds to the palm of
The
the
palmar surface.
patient. Yeah.
Yes,
Yeah.
sir. Yes,
Okay.
sir.
When so this is how you classify what is the percentage of the burns the patient gets. Okay. And as an anesthetist, when a patient comes, how do you assess a burns patient in an acute situation?
Sir, initially, airway breathing and circulation should be
Yeah, correct. Okay.
maintained, sir.
Yeah, correct.
And then should sedate the patient and give an analgesic.
Yeah.
Then according to the degree, the type of heat and percentage involved, the
Okay.
fluid management should be done.
Okay.
Then
Yeah, great.
antibiotics later on
Yeah, good.
after
So, yeah,
stabilizing.
antibiotic. Okay. So then, if it is the pre-hospital, if you are seeing a patient in the pre-hospital setting,
Yes, sir.
how do you manage hospital setting? Is what you are told. How do you assess in a hospital setting? In a
Yes, sir.
pre-hospital setting, so what you should do when you come across a burns patient?
You should put out the fire,
Yeah,
protect yourself
good.
first,
Yeah,
and then
protect you.
uh, put out the fire and under running water, it should be cold.
Yeah,
The surface
cold.
should be cold.
Yeah. So the burns has to be immersed in the cold water of 1 to 5 centimeter for approximately 30 minutes. Okay. Actually, this cold exposure is very useful when it is done before 30 minutes of burn. After 30 minutes, it's not going to help the burns patient, any burns patient. And try to shift the patient to the nearby hospital within 30 minutes.
Okay, sir.
Okay. So you have assessed and the percentage of burns has been clearly defined. Then with the percentage of burns, how do you calculate the fluid management?
So using Parkland formula,
Okay.
the total fluid which should be replaced in 24 hours, the formula
Okay.
says.
Okay.
So you should keep, according to the body weight, 4 ml per percentage of the burns per kg body weight.
Yeah.
So
Correct.
half of that volume
Hmm.
should be given in the first 8 hours.
Yeah.
And
Good.
next should be given over 16 hours. The
Yeah.
next 16 hours.
Yeah. Good. So is there any other formula to calculate apart from Parkland?
There is a pediatric formula. There, Galveston.
There is a Brook Army formula. Okay, there is at least you should know. Some examiners might ask Parkland formula. Is there any other formula to calculate fluid? So there is one called Brook Army formula. Okay, so that includes colloids also for treating. This is basically what you're told is crystalloids, and colloids also is there to manage the patient. Okay.
Okay, sir.
So how do you say your fluid management is good? Or adequacy of fluid management?
Depending on the urine output, sir.
Yeah, good. Okay.
It should be about 30 to 50 ml per hour.
It should not be so, no. It should be about weight of the patient, according to the weight of not 30 to 40. So usually it is 1 to 2 ml per kg per hour. And if you have a lactate, the lactate should be less than 2. And the base deficit should be less than 0.5. And the cardiac index and oxygen delivery index and everything If you have a central venous or a pulmonary artery pressure, then that should be in an optimal reading. Okay. Mainly it is about the urine output. Okay, urine output should be 1 to 2 ml per kg per hour. Okay. So is there any this thing where you can administer proteins in these patients or colloids? Usually this endothelial integrity is restored in the Burns patient within the first 24 hours of the Burns injury. So then after 24 hours, you can administer albumin, 5% albumin, maybe 0.5 ml per kg per Burns area, total Burns area that can be given. And that is about the protein management. Okay. And sometimes low dose of dopamine. Some centers start a low dose of dopamine with the 3 to 5 mics per kg per minute to increase the renal and the splanchnic blood flow. And early enteral feeding is encouraged. Okay. Within 6 hours, if there is no gastrointestinal or injury, then you can start the early enteral feeding. Okay. And main this thing of anesthetist is about the fluid management and particularly the pain relief.
Yes.
So what is the pain relief you will give for these patients, in the Burns patient? How do you manage the pain?
Sir, ketamine should be given, sir.
Yeah, ketamine, that is one.
No blocks.
No blocks. Okay, if it is confined to something, if it is a front of chest or neck or face, then the nerve block won't do much. So it is usually the now recent days they have started using intranasal fentanyl spray.
Okay, sir.
Okay, fentanyl spray or morphine 0.1 milligram per kg. Fentanyl, it is 1.5 mics or 1 to 1.5 mics per kg. And paracetamol can be used. Sedation, particularly, they will avoid because we never know the extent of injury to the trachea. They might go it for bronchospasm, stridor, and they will stop breathing. So it will be very difficult in those situations. And NSAIDs they have used depending upon the renal involvement or the hypovolemia and the percentage of burns. And gabapentin, they have been shown to cause good relief of pain.
Okay, sir.
Okay. So then what are the respiratory injuries which can cause in the Burns patient?
Injuries. So because of
usually,
can be caused because of inhalation injury.
Yeah, inhalation. Usually, this acute will not cross the vocal cord. Mostly, it will be above the vocal cord because of the hot air or the steam. Usually, that will cause laryngeal obstruction and bronchospasm. And because of smoke, actually, it is the heat. It will cause above the vocal cord. The smokes can cause below the vocal cord. The injury below the vocal cord. It can cause infection, atelectasis, or bronchospasm, and that can lead into pneumonia. The major cause of death in Burns patient is because of that is hypovolemia and infection. That is a major cause of death in the Burns patient. Okay. When do you intubate a Burns patient?
In case there is stridor.
Yeah. So when the patient is not able to protect the airway, consciousness is less because of smoke inhalation and carbon monoxide poisoning. And when that is basically inability to protect the airway, or the patient is having any severe respiratory distress, hoarseness of voice, or a patient is having any stridor, dyspnea, or the patient is having severe third-degree facial burns, and if you suspect carbon monoxide poisoning, these are the situations where you will intubate the patient. Okay. And
Okay, sir.
particularly, you should intubate the patient only after ascertaining that the nil oral of the status of the patient, or we should have a suction backup before intubating the patient.
Okay, sir.
Okay. So this patient of yours has neck, face, eyelid contractures. It
Yes,
is
sir.
posted for this contracture release.
Postpones. Yes, sir.
Okay. So particularly in the history, what are the main factors you will look in for? The one is the duration. What you told is 6 months.
Yes,
Yeah,
8
6
months.
months. 8 months. Okay.
Yes, sir.
Then whether the patient has any history of convulsions after burns, or any history of breathing difficulty, or any history difficulty in swallowing. Do your patient has these two?
Difficulty in breathing he had, sir,
Breathing.
initially.
Had, not now.
Yes, sir. No,
Okay.
sir.
So any history of snoring is there?
No history of snoring.
Snoring. Or any history of epistaxis or bleeding from the oral cavity?
No, sir.
So this history of epistaxis, then you can't go with nasotracheal intubation. So that is the this thing. And usually these post-burns patient will have a psychological problem. So you should assess the psychological status of the patient also.
Okay, sir.
Does your patient has any psychological problem?
No, sir, he has normal sleep. Decreased
Normal.
appetite alone he has.
Appetite alone. Okay. Then you should have a history of acid peptic disease and reflux esophagitis for these patients, because
He had
they
history
might
of heartburns.
heartburns. Now the patient has, or
The patient gives history of decreased appetite, so he does not experience heartburns.
okay, okay, okay. So
Initially it was more, now it's decreased.
okay, okay. So now before assessing the airway, going for airway, what are the investigations you will do for these patients?
So initially, the complete blood count should be done, and
Okay.
looking for the hemoglobin and
Yeah.
other
So this
normal.
patient is paler. No, you told the
Yes, sir.
patient is has paler. So hemoglobin and should be assessed. What is the hemoglobin level? Because these post burns contracture release usually will cause blood loss.
Yes,
So
okay,
the hemoglobin and the blood grouping has to be done, cross matching, and blood has to be
sir.
reserved. Then we should assess up.
Electrolytes
Yeah, good electrolytes. Particularly, what
should
you
be
will look in
potassium.
electrolytes. Yeah, potassium level.
Potassium.
Yeah, potassium level you will look into. Then renal assessment of urea creatinine, chest
Yes, sir.
X-ray AP lateral,
Yes,
neck
sir.
X-ray AP and lateral,
Okay,
isn't
sir.
it? So
Yes,
these
sir.
are
Yes, sir.
because there is a injury to the neck. You have to assess the thyroid profile also.
Okay, sir.
Yeah. Generally, what will be the analgesic requirement of any burns patient?
Be more depending on
Yeah,
the depth of the injury, it will be more than.
usually these burns patient would have received a lot of analgesics throughout this 8 months or initial phases. So they would have developed some tolerance towards the analgesics. So their requirement will be more intraoperatively. Okay, most of the patients would have got narcotics or whatever it is. So the requirement will be more during
Okay,
the
sir.
intraoperative period. That point has to be kept in mind. Okay.
Okay, sir.
And before going to other this thing, I think we should talk about scoline, which we use for burns patient. So any note you can give about scoline for the burns patient?
Sir, scoline should be avoided, sir, but in the
Good.
first 24 hours,
Okay.
because already there will be a hyperkalemia. So
Okay. The scolding is usually contraindicated in the Burns patient because the scolding can cause hyperkalemia. The potassium level can go as high as 13 milliequivalents. Okay, so when the potassium goes this high, what will happen? Patient might go in for ventricular fibrillation or ventricular fibrillation. Okay, so this hyperkalemic response in the Burns patient, usually it starts very early of 5 to 15 days after Burns, and usually it persists up to 2 years. So usually because of this duration, Burns patients are avoided with scoline. Okay, what is the mechanism? Why? What is the mechanism of this hyperkalemic response?
So because of post-junctional receptor, there is prolonged depolarization in the
extra-junctional. There is an increase in the extra-junctional acetylcholine receptors in the membranes of the Burns patient. Okay, when these receptors are stimulated, they can have a lethal efflux of potassium out of the cell. So this causes hyperkalemia. Okay. So usually it has been avoided. Scoline is avoided, and some patient has been reported with hyperkalemia even after 2 years. That's why they have recommended to avoid scoline up to 2 years of Burns. Okay. So what about non-depolarizing muscle relaxants?
During the initial 1 week, it should be avoided because there is resistance in cases of severe burns.
Not during 1 week. It is not 1 week actually. This non-depolarizing muscle relaxant has to be can be used, but only thing is it shows a great resistance. Resistance for in the post-Burns patient. Okay, so increase in the dosage might be required in the for the non-depolarizing muscle relaxant, whatever we use. What is the most common non-depolarizing you'll use?
For burns, sir.
Yeah. Most of the reports say that atracurium has been used for most of the patients.
Okay, sir.
Okay. So this extra-junctional receptors, they are very distinct. They increase in the number when in the post Burns patient. Okay, these junction receptors have a very short half-life of less than 24 hours. But our normal usual routine junction receptors, ACH receptors, have a half-life of about 14 days.
Okay, sir.
Okay, so these extra-junctional receptors are when stimulated, they are kept open for a longer time. Though apart from the routine acetylcholine receptors. Okay.
Okay, sir.
Then how do you classify the post-burn contracture? Mild, moderate, severe? How do you say it is mild, moderate, or severe contracture? Okay, so it is classified into mild, moderate, and severe with the degree of deformity because of the post-burn contraction. Okay, so it is classified as mild when the scar appears only when it gets appeared when the patient extends the neck, and the extension is around more than 90 degrees. Okay, moderate when the scar appears in the resting position of the patient and the extension is limited to less than 80 to 90 degrees. And the contracture is termed severe when the neck is in the flexed position. Well, your patient is in flexed position, no? That's what you told. Yeah. So that is a severe Burns contracture when the neck extension is less than 80 degrees.
80. Okay.
Yeah. Okay. So, what are the different ways you can secure the airway in a post-burn contracture patient? Or yeah, tell me.
Nasal intubation can be tried
Yeah.
because this patient does not have
Awake.
epistaxis.
Yeah, awake nasal intubation one.
Awake nasal. And fiber optic intubation.
Yeah, fiber optic
Video
intubation. Yeah.
And then LMAs can be used. Sir.
Yeah, LMA can be, but your patient has a very less mouth opening. Yeah.
Yes,
so the possibility of intubating LMA can be used if the mouth opening is more. Okay.
Okay, sir.
Video laryngoscope can be used. The surgical release can be done with Tumescent technique.
Okay, sir.
Local anesthetic, or you can go in for a surgical front of neck access. Okay.
Okay, sir.
So, what is Tumescent, by the way? What is a Tumescent local anesthetic? You have heard of this term, Tumescent?
I've heard, sir, but I'm not sure about.
Okay. So, Tumescent local anesthetic, it is a mixture of lignocaine with adrenaline. Some centers add hyaluronidase and saline. Okay. So, that is made into a total of 100 ml, 25 ml of 2% lignocaine, then hyaluronidase 1 or 2 ml, 1 ml of 1 in 1 lakh adrenaline, then saline, which is made to 1000 ml. Okay. So here the safe maximum dose of Tumescent solution we can use is 40 with that lignocaine. We can go up to 45 milligram per kg or 45 to 50 milligram per kg in some cases. Normally, what is the lignocaine dose with adrenaline?
2% lignocaine
with adrenaline. What is the safe limit?
7
7 milligram. Okay, 7 milligram per kg is the dosage of lignocaine. Here with the Tumescent, you can go up to 45 to 50 milligram per kg. Okay. Okay. So coming to the difficult airway assessment. What is a difficult airway? What is the ASA definition for a difficult airway?
Difficult airway is when a conventionally trained anesthetist is unable to is finding difficulty in bag and mask ventilation.
Good.
Or in intubation, or both.
Both. Good. So it is a conventionally trained anesthetist experience difficulty in mask ventilation or difficulty in tracheal intubation or both mask ventilation and tracheal intubation. So that is the definition, ASA definition for a difficult airway. So, okay, what is the difficult ventilation?
Is when a unassisted anesthesiologist is not able to maintain saturation of more than 90%.
Good.
With 100% oxygen.
Yeah.
In a patient whose saturation was more than 90% before an anesthetic intervention.
Good. So, what is the criteria to call to have a patient will have a difficult intubation? What are the criteria when you say it is a difficult intubation?
For difficult.
So when an anesthetist has more than 3 attempts to intubate, or when he takes longer than 10 minutes to intubate, or a failure to have a intubation. So these are called difficult intubation patient. Okay. Coming to few of about intubation and assessment. Do you have few or our textbook says we have to have a pillow under the neck during intubation, isn't it? Do you use a pillow or any sheet during intubation?
For difficult.
No, normal, routine, normal intubation. intubation?
Normal intubation, a pillow is used, sir.
Yeah.
On
Why
the-
pillow is used? Or what is the idea behind using, or what is the size of the pillow, head pillow to be used?
So to align the airway.
Okay, to align. So what is the size? Different patient needs a different size, isn't it?
Yes, sir.
Yeah. So what is the idea behind selecting the size of the pillow for a patient? Suppose a patient of 150 kilos or a patient of 40 kgs doesn't need a same size of head pillow, no?
No, sir. It
Yeah.
should.
So basically, the size of pillow should be selected to have the external auditory meatus and the sternal notch should be in the same line. Okay, that
Okay,
is
sir.
the size of the head pillow for intubation.
Okay, sir.
Okay, the cushion should be size should be such that the external auditory meatus and the sternal notch of the patient should be in the same plane. Okay,
sir.
so that is the size of selection.
Okay,
Okay,
sir.
can you tell me what are the steps routinely you do for intubation, laryngoscopy and intubation? Routine, not in difficult intubation, routinely. Like keeping a pillow, keeping a patient in a sniffing position. So just tell me.
The patient should be pillow should be kept below the head and neck, and
Okay.
after extending the neck,
Okay.
neck you should hold the neck in extended position and
Okay.
open the
Mouth.
open the
Open the
mouth
mouth.
and introduce the laryngoscopy from the right side of the patient to the left side, and after sweeping the tongue to the left side,
Okay.
the applying forward pressure should epiglottis will be seen, and
Okay.
in case the vocal cords are not visible, so the backward, upward, right pressure should be applied over the prequite cartilage, and once the vocal cords are visualized, the ET tube should be introduced.
Okay. So why I'm asking is there are so many steps in assessing difficult intubation patient. So all these steps has the predictors. I'm telling about the predictors. All predictors has few of the coherence with the laryngoscopy. What you have explained will come one by one so that we can correlate what it signifies in each predictors. Okay.
Okay, sir.
So when do you say it is you have successfully intubated a patient?
When
Which is a confirmatory test.
ETCO2.
Okay, good. ETCO2 is a confirmatory test. So any particular thing about ETCO2? How many trays you should see to confirm it is a ETCO2? I mean, successful intubation. Just it is not one or two traces. There should be a continuous 6 ETCO2 traces should be seen before confirming a successful intubation. Okay. So because if sometimes the esophageal intubation and the patient with the gas in the stomach or patient having an aerated drink can have a carbon dioxide in the stomach. Okay. So that can cause ETCO2 trace in the monitor. So the definition is that it's a clear-cut definition. There should be a continuous 6 ETCO2 tracing to confirm a successful endotracheal intubation. Okay, sir. Okay. For an difficult airway or any airway, not a difficult airway, any airway, how do you examine a patient? Starting from nose, there is a schematic of examination. So you should check the patency of the nose, then the incisor or the tooth, and what is the condition of the tooth, and incisor, intergum, incisor, this thing. Then tongue size, what is the compliance of the tongue, then whether you can see the uvula and the facial hair, whether the patient has had bird and so on. Okay, so when you come one by one, what are the predictors for difficult intubation?
Sir, assessing the TM joint function.
Okay.
Sir.
So to classify clearly, there are individual predictors, indices, and group indices. Okay.
Yes, sir.
So individually there is a physical examination. Individually there is a physical examination, radiological indices, and a few advanced indices. And there are several group indices. In the examination, particularly, they will be concerned and you will be asked only about the individual indices. And if you can have 2 or 3 group indices by name, that is fine. Okay.
Okay, sir.
So first thing, what you do in the patient during intubation is keeping a pillow under the head. So
yes,
the
sir.
idea is to have the neck flexion, isn't
neck
it?
Flexion. Yes,
yeah.
Sir.
So in thus assessing a patient, you should assess whether the patient has a good neck flexion. So how do you assess?
Sir. The sniffing position, the patient should touch his manubrium sternum with his chin by flexing his neck.
With the mouth closed.
Mouth closed.
Okay. So this should be with the patient mouth closed, chin has to touch the sternum. That means patient has a good neck flexion.
Neck flexion.
Okay. So next is the sniffing position. In our scheme of intubation, what you are told, next is the Atlanta occipital extension.
Yes,
okay, head extension. That is a sniffing position. So how will you assess that?
A hand should be placed, each of the hands should be placed, one below the occiput and one on the.
What is the name of that? That is a Delican.
Delican test.
Yeah. Okay.
And the patient should be asked to extend the neck. You should see if the right hand, which is on the chin, if it is moving up higher than the left hand, which is on the occiput, then it means there will be no difficulty in this sniffing position.
Yeah.
And if it remains on the same line, or if the right hand, the hand on the chin is on a lower level, then it anticipated difficult intubation.
Yeah. Okay.
In the position.
Yeah. Then one more is the alignment of the upper teeth. Just take a straight line. You can put a straight line in the arbitrary straight line in the upper teeth line. Then ask to patient to extend fully. Then you can make a arbitrary line. So that has a angle. So the measurement is made with a what is called as a goniometer. Okay. So grade 1 is if it is more than 35 degrees. Grade 2 is 22 to 34 degrees. Grade 3 is 12 to 21 degrees. And grade 4 is less than 12 degrees. So this is the grade of the angle. Okay. From 35 degrees to less than 12 degrees. The grade 3 and 4, it signifies difficult intubation.
Okay, sir.
Okay.
Okay, sir.
So any other test you can do to identify the patient has will have a difficult extension or stiff joints? One is the prayer sign. What is prayer sign?
The palmar surfaces of both the hands should be approximated. And if there is, if the palms are not
the palms and the fingers particularly.
The fingers are
not approximating each other, then there is a you can expect a cervical spine immobility. Okay, and they are yeah. Then other is a palm print. Yeah, fingerprint. Yeah. So there is a grading for palm print. Grade 0 is all phalangeal areas are visible. Grade 1 is deficiency in the interphalangeal area of the 4th and the 5th digit. Grade 2 is the deficiency in the interphalangeal areas of the 2nd to 5th digit. and grade 3 is only the tips of the fingers are seen.
Yes.
Okay, you understand this? This is the
Yes,
grading of the palm print. Okay, if you, it is good if you know at least the what is the basis behind it and the name of that. Okay.
Okay, sir.
So how do you assess the temporomandibular joint?
The mouth opening and the inter-incisor distance should be measured. Normally, it will.
This temporomandibular joint, if you come, the opening of the mouth, because we have to open the mouth to put the laryngoscope, no? To assess
Yes,
the
sir.
opening of the mouth, you have to assess the temporomandibular joint. Okay.
Yes,
So
sir.
this temporomandibular joint has two functions. One is rotation and forward displacement.
Yes, sir.
Okay. So this rotation will cause, because of this rotation of the condyle, it has 2 to 3 centimeters of mouth opening, and because of the forward displacement of the joint, it causes further 2 to 3 centimeters of mouth opening. So what will be the total mouth opening?
Normally, 5.
Yeah, 5. Okay, 5 to 6 centimeters. Okay, so
Yes,
that is how you assess the temporomandibular joint. Okay, then other this thing, what are the tests you can assess the temporomandibular joint? One
Yes,
is this one, mouth opening. The other one?
jaw protrusion.
Yeah, good. Jaw protrusion. What is this?
You should ask the patient to bring the lower jaw in front and see how if it can cross the trachea. Yes.
Yeah, well, lower jaw, you have to ask the patient to protrude. If the lower jaw comes before the upper jaw, that is one. And if it is in alignment with the upper jaw, that's the second class. And if it is the lower jaw can't be protruded beyond the upper jaw, it is the class 3. Okay.
Okay, sir.
Okay. So this is about the mandibular protrusion test. What is Kahn's test?
Sir?
Kahn's, K-H-A-N-S, Kahn's test. That is the upper lip bite test.
Yes, sir. Yes,
yeah, that name of the test is a Kahn's test.
Kahn's test.
Okay.
Okay, sir.
What is it?
There are 3 classes, sir. You should ask the patient to bite the
upper lip
with the lower incisors.
Okay.
The class 1 is if the patient can bite the upper lip above the vermilion line.
Yeah,
And
vermilion line.
Class 2 is he can bite below the vermilion line.
Okay.
Class 3 is cannot bite the upper lip itself.
Upper lip. Good. So that is the about the temporomandibular joint. Okay. So
Yes,
what about the next inter-incisor distance? How do you calculate that?
Inter-incisor distance by asking to keep 3 fingers between the upper and lower incisors.
Okay.
It normal is 3 fingers or
Okay.
more than 3 fingers.
Okay.
And if it is less than that, then
okay. So if you say the normal is 3 fingers, and if it is 2, it is a bit difficult laryngoscopy. If it is 1, it is a difficult LMA insertion, and if it is less than that, it is very difficult. Okay.
Okay, sir.
So what is Petals test? That's a thyromental distance.
Thyromental distance. Yes.
Yeah, but Petals test is a thyromental distance. What is the what does it implies, this thyromental distance? So it implies the mandibular space inside the mouth. So how you can push the tongue inside to the left side or the right side, depending upon the handness of the operator. Okay.
Yes,
so
sir.
that is the that implies the 1 minute. Just hold on.
Yes, sir.
Just hold on. Yeah, tell. Yeah, so this thyromental distance, it indicates the it can how much the tongue can be accommodated inside the mandibular space. Okay, how do you measure it?
From the thyroid gland to the
You know, they
chin, sir,
measure
the
the upper edge of the thyroid
mental
cartilage to chin with the head fully extended and mouth closed. Okay,
normal
so what is the normal?
should be more than 6.5 centimeters or
Yes.
4 fingers.
Yeah, okay. So if it is less, it is will be very difficult to displace the tongue.
Okay.
Okay. So what is the other test?
Hyomental distance is there.
Yeah, that is hyomental distance. Okay.
That normal is more than 6 centimeters.
Yeah, good.
Or 3 fingers.
Okay.
Then
grade 1 is more than 6 centimeters. Grade 2 is 4 to 6 centimeters. And grade 3 is less than 4 centimeters. So grade 3 is it is very difficult for laryngoscopy and intubation. Okay. There is a recent modification of thyromental distance. Okay. That is height to thyromental distance ratio, because some patients will have very high muffins, and few will be short. So these centimeters will not match each other, isn't it? So they recently they have made a study about the height to patient height compared to the thyromental distance, the ratio, and there is one ratio, I'm not sure, just check about that.
Okay, sir.
Okay. So thyromental distance, next is hyomental distance. What is next? Sternomental distance. Sternomental distance.
Sternomental distance is measured with the head in full extension, and the mouth should be closed.
Closed, yeah.
And normal distance is more than 12.5.
12 point. It is measured from the tip of the mentum to the manubrium. Okay, yes. With the neck fully extended and mouth closed. Okay, normal is 12.5 centimeters. It is a single best predictor of difficult laryngoscopy and intubation. Okay, because it has a very high sensitivity and specificity.
Okay, sir.
Okay, next comes Malamute.
Yes, sir.
Yeah. What is
so? Sir, it shows the pharynx to tongue ratio. The examiner should sit opposite the patient at eye level. The patient should be asked to open the mouth wide without any phonation. And the tongue should be protruded. Grade 1 is the soft palate is visible, the hard palate, soft palate, uvula, and the tonsillar fossils pillars are visible. Grade 2 is the soft palate, uvula, and grade 1 posterior pharyngeal wall might also be visible. In grade 2, only the tonsillar pillars are visible.
Okay.
In grade 3, the soft palate and only the base of the uvula is seen.
Okay.
In grade 4, only the hard palate is seen. And there is a grade 0 in which epiglottis is also seen.
Yeah, good. So basically it is 4 grades, and if they ask about what is grade 0, then you can say it when the patient epiglottis is very rare. And I have seen few patients when they open the mouth, you can see the epiglottis. Okay.
Yes, sir.
Okay. Then there is a length of mandible also is there. Okay. To assess the EC of intubation. So when the length of mandible is more than 9 centimeters, then it indicates there is a EC of intubation. And one more very important is about the neck circumference. Okay, when the neck circumference of a patient is more than 40 centimeters, it will be difficult intubation, and sometimes it will be difficult for the mask ventilation also. Okay. To summarize, what are the individual indices we have seen?
Assessing the thyromental joint function with the mouth
The
opening,
first is the neck flexion,
neck flexion, then
atlanto-occipital extension
atlanto extension,
by
and
grading and the Delican method, then prayer sign, palm print sign,
palm print,
then jaw protrusion, lip bite test, then inter-incisor gap, thyromental distance, hyomental, sternal mental distance, Mallamatti grading, then mandibular distance and neck circumference. Okay, so these are the individual indices for to assess the difficulty of intubation. Coming to your patient, for what are the things you have measured and how it implies?
So mouth opening is less than 1 finger, sir.
Okay, so if it is less than 1 finger, it will be difficult to insert the LMA also. Okay, yes, forget about laryngoscopy. Okay, then, yes, then extension, flexion.
Extension is flexion. The patient has a fixed flexion deformity, so fixed unable flexion to extend.
Okay, good.
Then Mallamatti not able to assess, sir.
Yeah, when the patient has an inability to extend or fixed flexion, the Mallamatti cannot be assessed, isn't it?
Yes, sir.
Yeah. Okay. So this is about your patient. So it is a grade 4, or you can say directly grade 4 Mallamatti and difficult intubation. Okay. Yes, so can you name some of the group indices of difficult intubation? Wilson's risk score. Yeah.
Binom of parameter analysis.
So there are several group indices. At least you should know by name each and everything. At least 2 or 3 you should know to tell. Wilson risk score, Benum's, then Shaggy's, Arnie simplified score model, and so on. What is lemon? LEMON, lemon.
It is the
L is for look. Okay, yeah, good.
Yes.
For difficulty in mask ventilation and difficulty in intubation. Okay, L is for look. Look is to look whether the patient has any facial trauma, or patient has any large incisors, patient has any bird or large tongue. So these are tongue, facial, this thing, and neck mobility, everything you have to look. E is for to evaluate 332.
Yes, sir.
Okay, 3 fingers in the interincisor, 3 fingers in the hyoid mental, and 2 fingers in the thyroid hyoid, floor of mouth. Okay, 2 fingers. And M is for Mallamatti. O is for obstruction. You can see, you can hear any obstruction or noisy breathing or stridor is there. And N is for the neck movement.
Yes, sir.
Okay. Sometimes the examiner, apart from that 332, they can ask what is 3321. Okay. So what is that one? 332 you have seen. 3 is for interincisor, 3 is for hyoid mental distance, and 2 for thyroid to floor of mouth. And what is 1? 1 is the 1 finger insertion in front of the tragus to assess the mandibular movement. Okay, in front of the you can put a finger in front of the tragus of the patient and ask the patient to open the mouth. You can see, you can assess the mandibular movement. Okay, that is 1. Okay.
Yes, sir.
Okay. What is POGO? One more this thing. POGO. That is a percentile of glottic opening.
Glottic opening.
Yeah. Yes. So when the percentage of glottic percentile of glottic opening, a score of 100, accounts for full visualization of larynx, starting from anterior commissure to the posterior cartilage. And 0 is the absence of glottic opening. Okay. If there is a 33 percentile, then it indicates there is a difficulty in intubation.
Okay, sir.
Okay, so that is the POGO. Okay, then there is a lot of other indices of difficulty in intubation. So coming to in a normal patient, you have assessed and there is some alarmity grading you have made. Further, after putting a scope inside, is there any other scoring after putting a laryngoscopy?
Oh, yes, sir. Cormac land scoring is there,
Yeah,
sir.
what is it?
Direct laryngoscopy. Grade 1 is the entire vocal cord is visualized.
Okay.
Grade 2 is only the posterior part of the vocal cords are visualized.
Okay.
And grade 3 is only the epiglottis is visualized. Grade
Okay.
4 is none of the glottic structures are visible.
Okay. So actually 2 will be divided into 2A and B.
Okay, sir.
Okay. So there is 2A is partial view of the glottis and 2B is only the arytenoid of the posterior part of vocal cord is seen. Okay. So Cormac and Lehane is 1, 2A, 2B, 3 and 4.
Okay, sir.
Okay. Is there any modification of Cormac and Lehane? There is a Cook and Fremantle modification of Cormac and Lehane. Okay. Cook C, OK, Cook and Fremantle. Okay.
Okay.
So just know about the name alone. That is just they have modified and they have included 3 also into 3A and 3B.
Okay.
That's it. Okay. In Cook modification, it is grade 1, grade 2A, 2B, 3A, 3B, and 4.
Okay, sir.
Okay. So this is about the predictors of difficult intubation.
Okay, sir.
Okay. Coming to your patient, what will be the mode of anesthesia or what will be the plan of anesthesia for your patient?
Sir, since mouth opening is restricted, oral intubation is not possible.
Good.
So, awake nasal intubation.
Awake nasal intubation. Okay. Yeah. So what other techniques you can employ for this patient apart from awake blind awake nasal intubation?
Fiber optic intubation can be tried.
Good. Fiber optic awake fiber optic nasal intubation. Then?
And if not tracheostomy.
Yeah. Retrograde intubation can be tried.
Yes.
Retrograde intubation and surgical access in the front of neck.
Yes, sir.
Okay, so these are the options you can, because we can't go with one technique.
Yes, sir.
Listen. So these are the other techniques you can go. So how do you? So now you have a plan of anesthesia. That is either you can go in for if you have a fiber optic, you can go for awake fiber optic intubation or a brain nasal intubation. Okay, if you select, if you say if you have a fiber optic scope, because it is blind nasal, okay, it has gone, the days are gone. To have a patient of, to intubate a patient of this, you should have a fiber optic in your setup. Okay, so you think you have a fiber optic and your plan is awake a fiber optic into nasotracheal intubation. Okay, this is your plan. How do you proceed with this patient? What are the things you will do for this patient? One is you should counsel the patient. Okay, so you should psychologically counsel the patient, because the patient will be awake throughout the procedure till you intubate and sedate the patient.
Yes.
Okay, so psychological counseling of the patient, you should clearly explain what you are going to do, what are the things will be happening in the OT. You will be awake and you will hear all the sounds and conversations and everything. So you should psychologically motivate the patient. Psychological counseling is must. Then after that, you have to take an informed consent for the patient.
Okay, sir.
Okay, then pharmacological preparation. Okay, so in this pharmacological preparation, what are the pharmacological preparations? One is you should pre-medicate the patient with glycopyrrolate.
Yes, sir.
Yeah. So 0.2 to 0.4 milligram at least 20 to 30 minutes prior to your plan of whatever they plan of intubation. Okay,
Yes.
0.2 to 0.4 milligram, so 20 to 30 minutes before intubation. Next, you should prepare the nose because our plan is nasotracheal, so you have to prepare the nose. How do you prepare the nose?
First, you should examine which side of the nostril is patent.
Yeah,
and
good.
In this patient, the left side is affected since there is left side facial
Yeah,
burn.
contracture. Yeah.
So right side is more patent. So that
Okay.
side should be
Prepared.
prepared. Yes.
Yeah. How do you prepare?
Nasal drops.
Yeah.
Should be.
So before that, to the coming to the blocks, can you tell me what are the sensory innervation of the airway? Because if you know that, then you know what are the nerves and what are the techniques to be blocked, isn't it?
Yes, sir.
Yeah.
The upper part of the airway is till the oropharynx is supplied by the trigeminal nerve.
Okay.
And below that is the glossopharyngeal nerve.
Okay.
Then below the thyroid, involving the cartilages, it is the vagus nerve.
Okay. To be very precise, the nose is supplied by the trigeminal nerve. Okay. The anterior ethmoidal nerve, which is a branch of a ophthalmic nerve. Then the greater and the lesser palatine nerve. Both are the branches of the maxillary nerve. Okay. So these are the nerves which has to be blocked in the nose. Coming to the pharynx, it is usually mostly it is by the glossopharyngeal nerve. Okay. So there's a glossopharyngeal nerve which supplies whole of pharynx, posterior third of the tongue, the fascicular pillars of the tonsil, and the epiglottis is supplied by the glossopharyngeal nerve. Okay. Coming to the oropharynx, oropharynx is supplied by the vagus, trigeminal, and the glossopharyngeal nerve. Okay. So posterior, as mentioned, the posterior third of the tongue, vallicula, anterior surface of the epiglottis are innervated by the tonsillar nerve, which is a branch of glossopharyngeal nerve. Okay. And the posterior and the lateral wall of the pharynx are innervated by the pharyngeal nerve, which is a branch of pharyngeal nerve is a branch of vagus nerve. Okay, vagal nerve. And the tonsillar nerve, also I have mentioned about the tonsillar nerve. Then coming to the larynx is innervated by the vagus. Above the vocal cord, that is the base of tongue, posterior epiglottis, aryepiglottic folds, and arytenoids are supplied by the internal branch of the superior laryngeal nerve. Okay. And vocal cord and below the vocal cord, it is the recurrent laryngeal nerve. Okay. So these are the nerves which we are going to address and block during the fiber optic intubation. Okay. So coming to nose, so we have to the preparation after the anti-skylock, you have to prepare the nose. For this patient, it is the right nose is patent.
Yes.
So we have to put a vasoconstrictor for this patient. 0.05 xylometazoline has to be put in the right side of the nose for this patient. 2 doses has to be put at 20 minutes interval. Okay. So why do you use vasoconstrictor? Vasoconstrictor is used to prevent the bleeding, okay, unnecessary bleeding. So xylometazoline, 2 doses at 20 minutes interval.
Okay, sir.
And lignocaine soaked cotton pledgets, 2% lignocaine soaked cotton pledget has to be inserted up to the superior concha, okay, to block the anterior ethmoidal nerves. And this has to be, this pledget has to be kept at least 20 minutes. Okay, so nose preparation is by vasoconstrictor, then lignocaine soaked pledgets till the superior concha for 20 to 30 minutes. Coming to oral preparation, there are two things can be done. One is goggling of 2% lignocaine, 5 to 10 ml. We have to patient is asked to goggle and hold for at least for 1 to 2 minutes, and patient should not be should be instructed not to swallow. Okay, because I have seen most of the patient giving goggling and then they will swallow. Okay, that will not serve actually. Goggle, they should hold it in the mouth for 1 to 2 minutes, then spit it out.
Okay, sir.
So this will block the posterior pharyngeal wall and the glossopharyngeal nerve endings.
Okay, sir.
Other thing is you can have a 2% lignocaine soaked cotton pledges. You can keep it in the anterior tonsillar pillar. Okay, that also will block the glossopharyngeal nerve. Okay, you're
Okay,
clear on the two, nose preparation
yes,
and
sir.
the
And
oral
oral
preparation.
Yes, sir.
Coming to the next is the superior laryngeal nerve. How would you block that?
1 to 2% lignocaine should be given on either side of the area and
Either side of what? So this is the superior laryngeal nerve is blocked near the greater corner of the hyoid bone. Okay,
yes,
to block this, the operator or the anesthetist has to stand in the same side of the block, whichever the side you're blocking, and you have to push the larynx to the side of the block. Okay, if you're blocking the right side, you have to push the larynx to the right side so that the hyoid bone will get prominent. Okay, then the needle has to be put in the greater corner of hyoid bone, slowly walked below to puncture thyrohyoid membrane. Okay, so after piercing the thyrohyoid membrane, 2 to 3 ml of 2% lignocaine has to be given on each side of the hyoid bone. That will block the superior laryngeal nerve.
Okay, sir.
Okay, next, how do you block the recurrent laryngeal nerve, which supplies below the vocal cord? For blocking both superior laryngeal nerve and the recurrent laryngeal nerve, patient has to be supine in position. Okay. So in the recurrent, to block the recurrent laryngeal nerve, patient should be in supine position with the neck fully extended. For this patient, though it is very difficult to extend the patient, whatever the position, try to extend as much as possible. Then identify the cricothyroid membrane.
Okay, sir.
Okay. Why do you select cricothyroid membrane? Because it is relatively avascular. There is not much of bleeding that can occur in the cricothyroid membrane. So identify the cricothyroid membrane and you have to insert a needle with a sheath. Okay. So after inserting or piercing the cricothyroid membrane, you have to take the needle out and you have to have only the sheath. Okay. Why? Because when you inject a local anesthetic, most of the patient, 99% of the time or 100% of the time, patient will cough. When the patient coughs, if you have a needle near the posterior wall, it is going to puncture the other side of the larynx. Okay. To avoid this, you should, after inserting, you should take the needle and, for example, you can take a Venflon and you can pierce the cricothyroid membrane. After piercing, you take the needle out and connect the syringe to the sheath, and you can ask the patient to take a deep inspiration. At the end of inspiration, you have to push 2 to 3 ml of local anesthetic. So after inspiration, patient usually has a tendency to cough. So when they cough, the whole of the local anesthetic will be spread below the vocal cord. Okay, so this will block the recurrent laryngeal nerve.
Okay, sir.
Okay, so do you understand?
Yes,
so
sir.
one is the nasal preparation, next is the oral preparation, block the superior laryngeal nerve, then the recurrent laryngeal nerve. Okay, so here totally we'll be using so much ml. So what is the maximum dosage we can use of lignocaine in anesthetizing the airway? Normally it is 7 milligram per kg, isn't it? Here you can go up to 9 milligram per kg. That is recommended for airway block of local anesthetic. 9 milligram per kg you can go.
Okay, sir.
Okay. So sometimes when you are okay, you can, when the patient is not quite little agitated or something moving around, you can give up to 0.5 to 1 mic per kg of fentanyl for this patient. Best is to avoid any sedatives or narcotics. But if needed, you can give 0.5 to 1 mic per kg of fentanyl. Okay.
Okay, sir.
Then you can pass the fiber optic with the tube loaded. Then you can go into the trachea. Then you can slide the ET tube down. Okay.
Okay, sir.
What is SAGO, SAGO? What is SAGO? SAGO is spray. Yeah, good. Spray as you go. So nowadays, most of the anesthetists they don't do this blocks and all. They spray as they go. Okay. So they spray the local anesthetic 1 ml or 2 ml on each stage when the patient is getting agitated. Then wait for 1 minute. Then go. When the patient is disturbed, then give another 1 ml. Spray 1 ml. Then you go. Okay. Most of the anesthetists now they go uses spray as they go with the fiber optics.
Okay, sir.
Okay, so this is the anything more want to discuss? So now we have discussed about burns, something about burns, what is the classification of burns, and how do you assess the burns, and management of burns, fluid management, and of course we have not covered about the antibiotics. Most of the centers has their own antibiotic protocol. Then they will start the antibiotics. Then fluid management of the burns we have seen. Then about the difficult airway, individual predictors, and the group indices. Then about the airway block and fiber optic intubation.
Yes, sir.
Okay. So now, anyone have any doubt about this? Want to discuss anything? Or you can send any message. I don't. Yeah, they have asked about the Tumescent composition. So Tumescent is the local anesthetic. Now I don't know whether they use. There are a lot of centers they have used or using, or they have used Tumescent local anesthetic. It is the composition of local anesthetic with adrenaline, hyaluronidase, and saline. I think there's a lot of disturbance. Can you hear now?
Yes, sir. Yes, sir.
Yeah. So Tumescent is the local anesthetic, as we have discussed. There is we can use up to 40 to 45 to 50 ml of local anesthetic to block. It is a combination of local anesthetic with adrenaline and hyaluronidase. Okay. So to prepare, it is a 25 ml of 2% lignocaine, then hyaluronidase 1 to 2 ml, and 1 ml of adrenaline, and remaining will be the saline. So we can use up to 45 milligram to 50 milligram per kg of Tumescent anesthesia. When we were doing anesthesia, we used to give the Tumescent in the post-burn contraction neck. They will release the contraction. Then they will then we will intubate the patient and put skin grafting or flap cover of for the contracture release.
Okay, sir.
Okay. Anything else you want to discuss? And by the way, next class, what we have scheduled is anesthesia for mitral stenosis patient coming for lower segment cesarean section. Okay, LSCS. So that will be scheduled on coming Tuesday, same 7 o'clock. Okay. So who are all interested, they can contact. Afrin, can you send in the chat box your number, so that they can contact you, or I'll send my number also. You send your number so that they can contact you and get the details.
Okay, sir.
Okay.
We'll send them.
Because the link I will send to the hospital HODs, and if you want, you can contact Dr. Afrin, and you can get the link from Dr. Afreen. Okay, she has given her number there. So this is my number. You can contact me as well. So next class will be on anesthesia for mitral stenosis patient coming for elective LSCS or LSCS. Okay, elective or emergency that we can discuss. Okay. So any doubt or anything anyone want to discuss about anything in the difficult airway? So this difficult airway is a must for every anesthetist in the theory as well as in the practicals. Any one or question will come in theory and alternate exam, and in the practicals definitely they will discuss whatever the case you go, some, because it is the basis of anesthetist for intubation. So some at least 5 to 10 questions will be on the difficult airway management. Okay.
Okay, sir.
Yeah, if everything is fine, can we close this meeting?
Yes, sir.
Yeah. Okay. So next we'll meet on coming Tuesday for anesthesia for mitral stenosis patient coming for cesarean section. Okay.
Okay, sir.
Yeah. Thank you, everyone. Study this after this. You go and study. You will remember most of the things. If you have any doubt, you can WhatsApp me. We can discuss. And if not, first 5 minutes of Tuesday, we can discuss about the doubts which I have received or which you are sending to Dr. Afreen. We can discuss about this in the first 5 minutes about difficult intubation or the doubts clearance. Then we'll go for the next session of class about discussion about mitral stenosis patient. Is it okay?
Yes, sir. Okay, sir.
Okay. Okay. Thank you all. Thank you.
Thank you, sir.